My name is Dr. Paul Jacob. I am an adult reconstruction surgeon in Oklahoma City, Oklahoma. A little bit of background: I grew up in Ohio, did my residency training in Columbus, and then my fellowship in adult reconstruction at the Cleveland Clinic. Very lucky to have had that opportunity. I'm grateful for that every day. The talk today is going to be about wearables, in particular orthopedic wearables, and Stryker's product, first product into that product line called MotionSense. So we need to start off by really talking about the difference between apps and wearables. So right now, most of us have access to patient outreach apps. A lot of the implant manufacturers and vendors have offered free apps through you to the patient, and there's a really significant difference between those two. We're going to talk about some of that now. So the apps really collect subjective data. They're asking the patient either PROMS questions or pain scores or things that they can't measure directly but need the patient to give input on. And obviously there's some disadvantage to subjective data. They're primarily education-based, so we're not collecting a lot of data, but we're really kind of preparing patients for their surgery and for their day of surgery and post-operative recovery. It's a great tool. It's a nice marketing device for practices, but it doesn't help you get better as a surgeon. PROMS data is really passive data. My problem with PROMS data, we always get inundated with outcome measures and patient-reported outcomes and all these scores, and they really don't mean much to our current patient. So that data that we're collecting is really for affecting the outcome of future patients. It doesn't really do much for our current patient, doesn't allow us to intervene currently and improve that individual patient's outcome. It requires patient interaction. So the patient has to enter that data into that app. They can't passively collect that data and have it automatically uploaded and pushed to you as the surgeon. They actually have to enter that. And we all know that as patients get better and improve with time, they're less likely to participate in interaction like that. The value is really questionable. So how much value can you place in subjective data? It's difficult to say. Some of it is valuable. In the case of pain scores, it's the best we've got. We don't have a device that we can put on the patient to measure their pain. And so sometimes we have to rely on subjective data, but the bulk of the data that we get from apps is subjective or not valuable to us as surgeons. So is this really becoming data for the sake of data? The word data is being massively overused right now. We're collecting all kinds of data every day, but very small amounts of that data is usable immediately for the current patient we're treating. And it's not data that we often interact with as surgeons on a daily basis, like range of motion, pain scores, steps per day, exercise compliance. Those types of information really aren't being collected by outcome measures and scores and validated reports. We just don't get that information. And so we're collecting all this, but we really can't do much with it. It's great for research, but in our clinical practice has very little application. Whereas the wearables primarily are collecting objective data. So the wearable has an app, and we'll talk about that later, and it's collecting some data, even some subjective data that we'll talk about. But primarily that data that we're collecting from the wearable is objective. It's factual. It's daily steps per day. It's real-time range of motion. It's time spent in weight bearing, exercise compliance. It can collect gait data and see when that patient's gait is normalizing. It's passively collected by the device and sent to the patient's cell phone and then pushed to the surgeon, again, passively. The value is immediately relevant to that individual patient. So there's very few things that we have in orthopedics today where we can say, I can intervene based on the data I'm collecting from my current patient now and improve their outcome by the end of this treatment course. And this is one of those devices that allows us to do that. And then it's data that we're used to interpreting. We are used to evaluating patients' range of motion when they come back at 2 weeks and 4 weeks and 6 weeks. We're used to asking what their average daily pain score is, how compliant they are with their exercises. But again, all this is subjective when the patient is telling it to us. We all have those patients that say, Doc, I'm doing everything I'm supposed to do, but I keep losing range of motion and I'm getting worse and worse. And we end up having to manipulate those patients or maybe even take them back to the OR. And this type of device can help you identify those patients who are being non-compliant and encourage compliance and therefore affect their outcome. So this is the device. This is what it looks like on the patient's leg. I'll tell you a quick story about the picture on the right-hand side of the screen. So that patient came running up to me at the gym, yelling, Dr. Jacob, Dr. Jacob. And I turned around thinking, I have no idea what's about to happen. And he said, I have to show you something. And he started pulling his pants down. And I thought, this is going to be interesting. And he was wearing the wearables. He was so excited to show me that he had those on. He had actually just run the Boston Marathon with the sensors on. So we got some really amazing data out of that. And we actually gathered a crowd. A bunch of people were asking what those were and wanting to know more about it. And so it was really kind of a neat first eye-opening for me of how impactful it is, not just as a device collecting data, but also to help market your practice and to individualize you as a surgeon in the community. I think one of the important things to stress about this is really the fact that we're collecting both preoperative and postoperative data. So we collect their average steps per day, we collect their range of motion, we collect their average pain scores prior to surgery. It's a really nice way of being able to show the patient postoperatively how they are actually making improvements. Often we have patients who just assume that they're doing very poorly or they're not doing as well as their physical therapist is expecting them to do, and showing them where they were preoperatively and where they are postoperatively is oftentimes exceptionally valuable. So this is what the patient gets. They get it comes in a box. That box is also used to recalibrate the device daily. It has a charging unit that they can put by their bedside. It has some additional adhesive strips that help the device stick to the skin. And then they get an instruction manual and the instructions on how to download the app. On the bottom right-hand side of the screen, that's the interface that we have as surgeons. That's what we see, and that's what we use on a daily basis to keep track of these patients. So pretty simple, pretty straightforward. You know, one of the things that a lot of surgeons end up asking me is, how do you work this into your daily workflow? And I have a nurse that's currently helping me do this, and we can talk more about that later. But what I'm finding is that patients need less and less assistance in setting this up and recalibrating it and getting into a daily routine than I had originally anticipated. So I've been pretty excited and pretty happy about that. So you can see here on the left-hand side of the screen, that's our interaction. We can do it on a desktop or an iPad. On the right-hand side of the screen, you're originally going to be asked to enter some data about the individual patient, the date of surgery and the context of the surgery. And then you'll see a simplified kind of basic chart view or workflow through the 5 or 6 things that Stryker's identified as valuable to us as surgeons currently. And we're going to take a closer look at that dashboard here. So on the left-hand side of your screen, that's the app. That's what the patients are seeing. So we're going to start off with some instruction to the patient on correct exercise compliance or range of motion, but it's a very simplified interface. It's done with a cartoon type character. So it really is a pretty simple, easy thing to follow. And they can see all their daily data collection. It really becomes a challenge to the patient to improve their steps per day each day to get a little bit better on their range of motion and continue with their exercise compliance. You can see here on the right-hand side of the screen, this is what we see as surgeons. So do I click on every one of these patients every single day? Absolutely not. You can see here at the top, George Wilson, who is a fake patient. So all the data that we're going to see in these next couple of slides, all are not real patients, so we don't have to worry about HIPAA violations here. But George has alerts on the right-hand side of his screen. So when you look over here, he's got 3 little yellow buttons. That tells us that he has some information that we think is important to have you take a look at as the surgeon. All these other patients have no alerts. They're doing quite well. They don't have any issues or problems or concerns. So there's nothing really to kind of open up and look at this point. You could peruse all the data you'd like. You're still able to look at that data, but you aren't being cued to maybe pay some extra attention to that patient. So here's George's day 14 post-op pain scores. And you can see here that he's been doing pretty well preoperatively. He's averaging somewhere between a 3 and a 6. And post-operatively, of course, early on, he's hurting. Maybe that's the day the block wore off. A day or two later, he's got his pain back under control pretty nicely. You can see there's a big spike here, and maybe we want to pay attention to that. So here we get an alert, 8:30 a.m. We have the date and how far post-op the patient is. That says that, hey, this patient's rating their average pain score low, but today it spiked very high. And so maybe that prompts us to look at some additional data. You can see here, this is the simplified workflow right in the middle of the screen. So it shows the patient's range of motion, pain scores, exercise compliance, steps per day, time, the device time worn, and the time that the patient was active throughout the day. So that's a great snapshot of some really simplified data that we're used to looking at every day as surgeons and identifying what's important to us. So just the pain score alone wouldn't prompt me to reach out to this patient. This is their post-op day 14 image that they're sending to us. So all the way on the left-hand side of the screen, you can see the date they sent it, how far post-op they were, and you can see a progression of those images through the recovery. So if you see an image that looks pretty good, it's not very swollen, and then the second image looks a little bit red, a little bit more swollen, and as you work through that progression, you see a change, and that patient's starting to rate their pain score higher. That may be somebody that you're paying a little bit closer attention to. You can see on the left-hand side here, this is what the patient sees. It's a really simple interface. They see a camera, they click on the camera, they point it towards their knee, they take the picture, and it's uploaded. So it's really a simple, easy user interface. You know, as we all are, I was concerned about my patient population, and obviously 65 and older primarily, being able to and wanting to use an app like this. Was it straightforward enough? This is so simple and so easy. I haven't had a single patient quit because they said, I just didn't understand the app, or I had trouble getting into it, or anything like that. It's been a really easy process. This is the exercise alert page. So this patient not only had a spike in pain, but they also only participated in one of their 2 assigned exercise sessions for the day, whereas previously they've been participating in 100% of their exercise sessions. So this is somebody that I may keep an eye on. My eyebrow is certainly raised and I have some concerns, but I don't know that at this point I'd be ready to reach out to that patient. And lastly, here we're going to see some range of motion data. So this gray line is the population mean. It's data that Stryker's collected from several established, well-known clinical studies documenting range of motion. And then we're going to compare our patient's range of motion at the 95th percentile to the patient's range of motion or the average population mean range of motion. So it gives us some data to compare. Is our patient where they really should be? If they're not, how far behind are we? So you can see on extension, we've got a 30-degree flexion contracture here, and we're falling outside of the population mean, although we're starting to come back to norm. So again, somebody I may take keep an eye on or take a look at, but not somebody I'm incredibly worried about, especially 2 weeks into their recovery. So I'm going to kind of demonstrate some value that I found in my personal clinical practice to kind of take a step back. I'm in private practice. I operate out of a physician-owned hospital. It's primarily an orthopedic hospital. And so I'm not doing academic research and clinical studies. I don't have residents and fellows. So this data is applicable to my everyday practice. And I think that's important to stress, that even the guys in the community who maybe have a busy practice and don't have a lot of resident or fellow assistants are still using this data and still making it valuable to them. So this is my very first MotionSense patient. He had some preoperative data that he collected for us. He had been doing quite well. His range of motion was kind of lacking preoperatively. He was averaging around 90 to 95 degrees preoperatively. We had his average daily pain score, his average exercise compliance, his number of steps per day, average time worn. All that data was available to us before we ever operated on this patient. Then we did the surgery, and on day 14, I got an alert that said the patient went from an average range of motion of about 91 degrees of flexion to 130 degrees of flexion. And he rated his pain score at a 10 out of 10. He had never rated a 10 prior to that. And so we were prompted, obviously, to reach out to him. And I thought, gosh, maybe the sensor malfunctioned. Maybe we got some bad data. I don't know. But we decided to reach out to the patient, primarily because this was our first go round. And when we called him, he said, "Why are you calling me?" And I said, "Well, we saw this spike in range of motion here, and we were a little bit concerned about you." And he said, "I can't believe it. I just slipped and fell in my garage, and my leg bent up underneath me, and my wife was loading me up to get me in the car to head to the emergency room." And I said, "Well, don't head to the emergency room. Just come on over to my office." And he ended up being seen in my office. About an hour later, we got x-rays, examined him, put some ice, elevated, gave him a Toradol shot in the office. And by that evening, he was back resting comfortably, and you can see his pain scores came down immediately. We saved that patient a trip to the emergency room, exposure to COVID, let's say a minimum of $8,000 to $10,000 in medical bills. If you're in a bundle, certainly that would have broke your bundle at that point. We are in a CJR market. And so we were able to not only make this significantly more convenient for the patient, but save the entire healthcare system a pretty significant amount of money. Plus, maybe we save that patient from being exposed to COVID and the emergency room workers from being overworked. I know that, I don't know that anybody else shares this experience, but every time I send a patient to the emergency room, they get a head CT. I can't keep the ER docs from not taking my wound dressing down. So they take the dressing down. They often don't have anything to cover it with again. And in the wrong emergency room, somebody's going to try and stick a needle in that knee. That can be a big problem. So immediately the value of this wearable was evident. Everybody was really excited about this. Everybody was blown away. And we just kind of went from there. I'll share my second experience here. So this is an anorexic patient, young lady who had had multiple previous right knee surgeries, including high tibial osteotomies, which got infected, multiple irrigation debridements for that. She was about 8 years out from those surgeries. We went in and took the hard route and did a total knee. She was doing exceptionally well. You can see her average daily pain scores were doing phenomenal. But over time, as we got closer and closer to that 30-day mark, her average daily range of her pain scores were increasing. Her average daily range of motion was decreasing. Her exercise compliance was decreasing. Her steps per day were decreasing. And I ended up reaching out to her and asking her to come in and get seen. We took her incisional dressing off, and immediately I had concerns. We ended up getting some blood work, and her CRP was pretty markedly elevated. So we took her to the OR, washed her out, and changed her polyethylene, essentially a simple DARE procedure. She ended up doing quite well, didn't need any long-term IV antibiotics, didn't need reoperation, fell right back in line and did quite well. Now, I can't promise you that we saved that lady from a long-term periprosthetic joint infection and multiple staged revision procedures, but I feel pretty strongly that we were heading in that direction. And so both of those cases alone, that was in our first 66 patients, saved potentially hundreds of thousands of dollars in healthcare cost, both to the patient and to the hospital system, the healthcare system, and my individual practice. From a clinical data standpoint, we have collected a significant amount of data as we've gone through this process. So we have multiple publications. The first and I think most notable or most important to me is the fact that we have published clinical data on the accuracy of this device. We're within plus or minus 2 degrees to licensed physical therapists who have a minimum of 10 years of experience, who measured with a goniometer. Then we measured with our sensor. Then we also measured with a camera system with markable technology. So we compared all three of that set of data, and we were within plus or minus 2 degrees on every single patient throughout that. The current clinical standard is plus or minus 5 degrees, so we're quite a bit more accurate than what the published data is currently using as the gold standard. On top of that, we've been publishing about the importance of the data that we're collecting on motivating the patient, on evaluating outcomes before, during, and after surgery, on compliance with the wearable, because that's oftentimes what everybody tries to knock about the wearables. Patients aren't going to wear it. We have 80% compliance for an average of 80% compliance over a 90-day period with the wearable and on compliance with wearing it and charging it and using it. So I think that's pretty impressive data. The average wear time per day is about 10 hours. And that's through that 90-day period. So again, better data than we ever had anticipated. The patients are enjoying it. They're wearing it. They're using it to push themselves. It's also quite a bit motivational to know as a patient that my surgeon can see if I'm skipping my exercises or I'm losing range of motion, or maybe I just don't wear it for a couple of days because I'm hurting and I don't want my surgeon to see that. It also triggers us to kind of reach out to at-risk patients maybe a little earlier than we would. And that patient really shares that story oftentimes with multiple people. You know, my surgeon called me before I even called their office and was asking if everything was okay. So the first time you do that, they realize, yes, he is paying attention to the data. Yes, I need to do this, and I'm going to be held accountable. So what's the difference between a wearable like a Fitbit or an Apple Watch and a wearable like the MotionSense device? And really, it comes down to one simple thing. I want orthopedic specific data. I don't really care about, and forgive me to my cardiology colleagues, but I don't care about the patient's heart rate or some of the data that those types of devices would collect. What I really want to know about is the stuff that I'm asking the physical therapist when they call me with concerns about a patient. What's their range of motion? What's their pain? What's the knee look like? Are they functional and active, or have they been skipping therapy sessions? I don't need to call anybody. I don't need to reach out to anybody, and I don't need to get interrupted during my day because I already know that data. I've already reached out to the patient. We've already addressed the problem, and we're already on to improving recovery. Wearables have the ability to passively collect data and then to send that data to the surgeon. And then the surgeon has the ability to upload that data into an EMR. So when we're talking about, and we're going to get into this with the next slide or two, but when we're talking about billing and coding and reimbursement, we need to prove to these insurance companies that we're actually doing what we say we're doing. So how do we record the fact that we're monitoring these patients, we're collecting the data, we're utilizing the data, and we're improving outcomes? And that's what we're currently doing, but we're going to talk about that in a little in a second. So this is what we're really talking about for reimbursement. There are some specific codes that were identified for orthopedic wearables. These codes are remote therapeutic monitoring codes, and they are, again, specific for orthopedics in particular. And they allow you to bill for the education and onboarding, the cost of the device, and then the time spent monitoring the data. So you need a minimum of 16 days worth of data to be able to build the code. And you can build that code every 30 days as long as you're collecting a minimum of 16 days of data within that 30-day period. I don't know about you, but I certainly don't have time to monitor that. When we first started this process, we ended up trying to build an Excel spreadsheet that would identify us or alert us every 16 days and at the end of every patient's 30-day period. As you can imagine, every day you're onboarding a new patient, and so that information has to be entered into the spreadsheet, and you have to check the spreadsheet every day. It really became overwhelming and quite tedious. So as of Monday, I believe the Stryker team has launched a new portion of the app. I cannot tell you how excited I am about this. It's so valuable. For some of you guys who haven't been using a device like this yet, it may not be as meaningful to you, but it is incredibly valuable to you and your team. So every patient is going to have a data tag or a data status tag associated with their name. And so when they have had a minimum of 16 days of data collected and it's within that 30-day window, that tag will turn green, indicating to you that you need to bill the patient for remote therapeutic monitoring on that day. If the code is yellow, it tells you, yes, that patient is ready to be billed, but you haven't met the minimum criteria, so you haven't collected 16 days worth of data. So that's a person that I would ask my nurse to reach out to and prompt them to please participate with the wearable and find out if there are any issues or problems or concerns. You can then download that data and export it directly into your electronic medical record system. So if you're ever audited, you have all that data, every bit of what you did, how you did it, when it was collected. It's all in your electronic medical record system and documented in the chart. And that's all done passively. So you don't have to participate in that process as the surgeon. I really can't stress to you how important and how valuable this new application is. So this is just a kind of a closer look at what we just talked about. When the tag is green, it means that you've collected at least 16 days of data in that 30-day period and that patient's ready to be billed. If it's yellow, it tells you that you either don't have enough days in that period, or you have enough days, but you don't have enough data. And so it's going to tell you that you need to reach out to that patient. That's an at-risk patient, and we need to collect some data or figure out why they're not utilizing the device. And then gray is either data isn't met, so you haven't collected 16 days of data in that 30-day period, or you haven't had enough days to collect data, but gray means don't bill. It's a pretty simple format. Status alert, I think it's incredibly valuable. So to wrap up, we're going to wrap up here, and then we're going to have a period of time where we can answer some questions, and hopefully you guys will feel comfortable asking me anything that you'd like. But this is really the family of products. So you've got the wearable on the left, you've got the app for the patient, and then you've got the simplistic interface that the patient has that really makes it simple for you, your staff, your office, and the patient. I do think we see a decrease in the number of phone calls that the office receives. I haven't had problems with these malfunctioning or falling off or issues like that where it's actually increasing our interface with the patient. I think we've had one or two patients who have elected after a certain amount of time to stop using it. And the patient that comes to mind had a immediate family member pass away, and she was just a bit overwhelmed and just didn't feel that the time it required was valuable for her at that point, and certainly very understandable. So can I answer any questions? Is there any discussion or dialogue?
Dr. Jacob, I had a few questions that came through that I can kind of read off. So how easy or hard was it to get the technology integrated into your practice?
Well, that's a great question. It's probably the most common question that people ask me. And originally, it was my biggest hurdle. I adopted this very early on, and we started the clinical data collection maybe a year ago now. And my big concern was, do I have to hire somebody to do this? Am I going to have to add additional staff? Am I going to be overwhelmed with complaints or problems or issues or troubleshooting? And as I previously mentioned, it's been shockingly easy. So I identified one individual in my office that onboards every single patient. I have cross-trained a second person. And so she interacts after I see them for the H&P. She comes in and talks to them about the wearable, tells them, hey, Dr. Jacob thinks this is valuable. And I will tell you that that's the number one question the patients ask me is, do you want me to wear it? Do you think it's valuable? When I say yes to that, it's often, the discussion is often over. They say, hey, if you think it's valuable and I need to do it, I'll do it. And so the patient then gets onboarded with the app. Elaine goes over how to calibrate the device daily and how to charge it. And then they're off to the races. And we send them home to wear it preoperatively. So they've worn it for oftentimes a month prior to surgery. And they feel very comfortable with it. They've calibrated it over and over again. They've gotten into a routine. And so by the time they have the surgery, it's not overwhelming. They're not trying to learn how to utilize the wearable while recovering from a very painful surgery.
Perfect. And that leads into our second question, is how is the overall patient engagement post-operatively?
It's been really exciting. I cannot tell you how many people come back just raving about how cool the device is and how they love seeing their data and essentially competing against their self. I do think it's exciting. Stryker about quarterly adds new features to the device. So as we grow and understand the device and the data that it collects, they continually add valuable options based on surgeon feedback. And so they're listening and improving quarterly often. And so as we go through that, it's getting better and better. It's getting easier and easier. And I certainly think it's something that's incredibly valuable to the patient. They give great feedback. Interestingly enough, I've had several patients that came to me because they saw a patient in physical therapy wearing the sensors. They got a chance to talk to that patient and then thought, my doctor doesn't do that. I'm going to go to this guy. And so it's been kind of interesting.
And then just to go back to your range of motion story, we had a question that said, do you get alerts if there is a spike or concern when it comes to range of motion? Just to reiterate that.
Yeah, you don't get a text or a notification box that pops up on your phone. You get an alert if you log into the software. Obviously this was our first patient, so we were paying pretty close attention to what was going on. And so I was probably logging in more than I would log in today. That's something that we've gone back and forth with from a design standpoint, is how much, we just had this conversation, but if you get too many alerts, just like on your cell phone, you end up swiping them away and not paying attention to them. So we want to alert you to the stuff that is really important without burdening you with alerts and in turn desensitizing you to them and to the data they're providing. So we walk a fine line there. I don't know that I would have caught it directly like I did that last time, but I certainly would have seen it that evening and reached out to the patient directly, and maybe I would have caught him in time.
Another one we just had come through was, can you use MotionSense with OrthoLogic with all implant systems or just Stryker?
All implant systems. It's not implant specific. If they had a total knee, or they had an ACL, or they had a knee scope, or they had any high tibial osteotomy, whatever procedure you may have done to that knee, if it's a patient you want to monitor, they can use the wearable.
And then it looks like one last question is, how has this affected your practice's efficiency with patients?
Yeah, that's a great question. That was my, number one concern was, is this going to overwhelm me? Is it going to add to the burden that my office already suffers from? And the thankful answer was, after about a week or 10 days, it changed zero in my daily workflow. We got a kind of a routine together on who was going to go in when and talk to the patients, how would they be introduced to the product, and then how would they be trained on the product. That training, which was originally taking us 10 to 15 minutes, now takes us about 2 minutes. Often the patients are kind of glossed over as we're talking about it. They're going, yeah, I get it. I can do this on my own. I really don't need you to go through this with me. And the app is incredibly instructional. So it will not only talk to the patient about if there's a problem, how to troubleshoot some of that stuff, but it takes them through the calibration process and some of the things that eliminate workflow for your office and your staff.
And we had two more come in. One that says, typically how long from a duration standpoint do the patients get monitored after surgery using the MotionSense wearable?
Patient's compliance with the device drops off the closer you get to 90 days. It really doesn't start dropping off till you get to about day 65. So at day 65 to day 90, a well-functioning patient starts to wear it less and less. For remote patient monitoring codes, you can't have two doctors monitoring a wearable at the same time. So if the patient has some sort of a blood sugar device that their endocrinologist is monitoring remotely, and you're billing for it, you both can't do it. Remote therapeutic monitoring does not have that same limitation. So there are some differences in remote therapeutic monitoring and remote patient monitoring. I'm certainly not a billing and coding expert, so I would just kind of defer those types of questions to your billing and coding team.
Sure. And then another one, we had a couple more come through. So do patients or caregivers also get any alerts in the app, or do they come to visit the doctor's office?
They don't get alerts per se, but they see their own data. Now, I would love for the patients to start being able to see benchmark data. So where is your aged matched cohort at during this phase of your recovery in a sort of a broad range? So we're not disincentivizing patients, but often encouraging them to compete against their age matched cohorts. I'd love to see that, but the patients don't get alerts on their phone. But they can see if the data, if the app is saying that they're only 24% compliant with their home exercise program, they see that and they know you see that.
So following up from that a little bit too, is have you seen this reduce or eliminate the need for follow-up visits, given the data that you and the patients are seeing?
Yeah, I actually have patients who say, do I really have to come in? I mean, you know how I'm doing and I feel great and I'm not concerned. And when I send you a picture of my, incision, you reply. I feel pretty comfortable not coming in. So I'm fortunate enough to have a pretty big, pretty busy practice, and we operate on out-of-state patients. This is an awesome tool for out-of-state patients, or in my particular state of Oklahoma, we have lots of patients who travel to the city. Rural communities often either don't have medical care, or certainly not higher level surgical care, and definitely not robotics. So they'll drive all the way to the city for their surgery, but they don't have to come back 5 times for what they feel is unnecessary follow-up. So if you can see an image of the wound and follow their progress on range of motion and exercise compliance and whatnot, you can certainly justify the fact that you are monitoring that patient, maybe even closer than you'd monitor a patient who's coming into your office. And it's a very valuable tool for you, the surgeon, and the patient as well. Often improves their comfort level with less follow-up.
And then a little bit of a two-part question. Have you changed anything within your intraoperative technique of a total knee after you started MotionSense? And has the technology changed the way you've treated patients post-operatively as well?
Oh, that's an awesome question. So at patient 66, I decided that I was a tight knee guy, meaning I really liked a tight feeling knee. I didn't want a lot of sloppiness as I was checking valgus and varus stress at the end of the case. I wanted to feel that stability throughout the entire range of motion. What I was seeing was my flexion numbers really weren't as good as I, in my head, thought they were. And that's one of the things that MotionSense really opens your eyes up to, is the fact that maybe our range of motion isn't as good as we thought. Maybe it's not as good as early as we thought. Honestly, when I started this, I thought, man, all of my patients are at 130 by week 4, like 100% of them. And it really opened my eyes. The other thing that we have to get used to is this isn't data where the physical therapist is forcing the knee into flexion and then measuring with the goniometer. This is the patient's active range of motion, not active assistive range of motion, not passive range of motion. So it is incredibly valuable to demonstrate to the patient that certainly they're improving. What I really love to show is the patient who could only flex to 86 degrees preoperatively and had a 12-degree flexion contracture. I can show them at day 21 they're at 101 of flexion and have full extension. That's massive improvement. Now the physical therapist is probably telling that patient, wow, you're way behind, we should be doing much better than this. But the physical therapist doesn't know that preoperative where that patient was before surgery. Oftentimes the patient doesn't know, and they don't understand range of motion numbers. And so when you show them how much better they're doing, it's incredibly motivational for the patient.
So has this been used at all to compare a manual outcome to a robotic assisted outcome?
Not yet, but we're publishing as fast and as furious as we can. And I think you can, as you guys have already probably started doing, the research applications are immense for a device like this. Not only to compare maybe robotics versus manual, but implant to implant, manufacturer to manufacturer. There are so many potential advantages here, that this is so early on in this market. We're not even scratching the tip of the iceberg. Wearables and implantables are what is next in orthopedics. I strongly encourage you guys to be early adopters, go through some of the headaches and the learning process. It's one of the most valuable tools I've adopted in clinical practice since the start of my practice. That includes robotics.
And then two questions in one. Do most of your patients have smartphones? And what else would qualify for an ideal patient selection?
I would tell you, I'm surprised at how many patients have and heavily utilize smartphones. 65, 75, 80-year-olds that are proficient with with smart technology in general. Often they're already wearing an Apple Watch or a Fitbit or some sort of device. Pedometers seem to be incredibly interesting to that patient population. So they all have some sort of pedometer they're wearing. And this kind of ticks that box, but it starts off as a neat gimmick, and it becomes so much more so quickly. The patients immediately identify the value. So I haven't had hurdles because the patients don't have the ability to adopt the technology or the desire to adopt the technology. Even in my rural communities, I would say the bulk of patients have some way of participating. What was the second half of that question, Michelle?
Oh, and then what else qualifies for good patient selection for
me? For me, I think it's patient interest. That's the number one most important thing. If I have a patient who's if I go through my spiel and I give my talk and the nurse comes in and talks to them and they go, I don't think I want to do it, I don't push. I just stop, because that's somebody who's not going to be compliant with the device. They're not going to charge it daily. They really, this is Oklahoma. There is a lot of my patients don't want somebody monitoring them constantly, and I totally get that. There is some concern about, is this a little creepy? And for me, I was genuinely concerned about that at first. I haven't had a single patient. I had one patient ask me if the government could monitor the data too, which I thought was really interesting. But obviously, most people really aren't concerned about that and enjoy the wearable.
And then, question in regards to patients. Have you seen new patients coming into your practice asking for this?
Yeah, absolutely. The physical therapy clinic's the best way to market this device. So I actually am somewhat concerned in that I'm getting patients who saw a patient in the clinic that was wearing the device, said, oh my gosh, I got to know more about this, started talking to the patient. Now they've come to me for their second knee replacement, even when they were happy with the outcome from their first knee replacement from the other surgeon. That is something that I worry about, because I think, oh my gosh, what if I don't deliver here and the patient's unhappy with my knee replacement and is going to gripe and complain? But it's a good problem to have, and I'll take it any day.
You know what? On that note, I think that was the last question that we had for the night.
Awesome. Thank you so much, guys. I appreciate your time and energy and attention.